Hello, welcome back to another episode of An Unorthodox CEO. I am, as always, Steve Pickering, CEO of Sussex Beds, and today we're joined by Dr. Nick Harvey. Hello, Nick. Doctor. I was a dick then, but Nick.
We can talk about that.
Oh no! Maybe I was on the mind. Nick Harvey joins us today, and we're going to be chatting about why Nick chose to study medicine. Yeah, what took you down that road, and the pressure that comes with being a doctor. And why innovation is so important in medicine and doctoring, I guess. Yeah.
Okay.
So there we go. But before we go any further, don't forget to hit that subscribe button now, because you do not want to miss out on any future episodes. There we go. Yep. Click. There's a few more on the subscribe button there. Good. Thank you very much for doing that. Yeah. Brilliant. Well. Welcome, Nick.
Thanks, Steve. Thanks for having me.
Thank you for coming across. And you've come all the way from Eastbourne. And I was waiting for a call to pick you up. And then we discovered, so we're right at the top of Hastings at St Leonard's. And Nick got the train across. And then we discovered that he cycled up to the office. I was ready to come and pick you up, and you cycled.
Yeah,
wow.
Well, it's important, isn't it? I try and do as much as I can under my own steam. If that's going upstairs rather than the escalator,
yes,
or cycling or walking, I think we're made to move as human beings.
Yes,
I try to set the example.
And cycle up to here. Well, that's amazing. And we were just talking about electric bikes before we come on, and the importance of doing little bits, really, isn't it? It's not about doing.
Absolutely. Let's dive into that then, because since you're prompting me, this is a big thing behind what I'm trying to do through the Federation and Hillbrow that you wanted to mention later.
Yeah.
And it's really important to know that, our bodies are made to move, and we know that 1 in 4 people are inactive, so that is classed as less than 30 minutes of moderate intensity exercise a week. Moderate intensity exercise is the sort of exercise or activity that makes you slightly short of breath. So you could talk still, but not sing, that kind of level.
Yeah.
Now,
well, I can't sing when I'm not doing nothing either. So it goes both ways.
That's it. You're exercising all the time.
Yeah.
And actually, if you do none of that and you go to doing 30 minutes a day, the risks of you developing things like dementia, heart attacks, several types of cancer, strokes, go down by 30 to 40%. And hip fractures, if you've ever had a parent or old elderly relative, if you keep people active, that reduces by about 80%. So this is huge. So as a GP, I see people who are unwell all the time, and I got really frustrated that I'm seeing people that actually maybe 50 years ago I wouldn't be seeing. We're seeing more and more people who are unwell, maybe because of the lifestyles that our culture is kind of cultivating.
Yeah. So 30 minutes a day is what you're saying?
30 minutes, 5 days a week.
Yeah.
It can be whatever you like, and it can be in small, it adds up. So it might just be 10 minutes at a time.
Yeah.
It makes a huge difference. The other one I messed off was mental health. But who would have guessed dementia? 30% reduction in dementia if you keep physically active.
So how does that link then, exercise to dementia? What is it that stops that or reduces that? Yeah,
we don't truly know. And of course, some of this might be an association rather than a causation. So we need to be a little bit careful. So if somebody exercises, maybe they're less likely to have an impairment of their cognition anyway. So we need to be a bit careful. But we do know that exercise uses up the energy that's sat ready in our cells.
Yeah.
And when there's energy kind of sat there, if it's not used up, it causes some damage, and that's where the cancers and the furring in the blood vessels and things like that can come from. And similarly, we think with dementia, that if you don't use the energy that's sat ready to be used, it gets up to mischief. causes other bits of damage.
Right. Yeah. Okay. Yeah. I mean, we've sort of skipped on, but that's probably my fault. But so you're a doctor. Did you always want to be a doctor, or is it?
No. So I suppose I thought of it when I was 16 after my GCSEs.
Yeah.
I did better than I thought I did. I knew I wanted to go in healthcare, and I thought, oh, the grades aren't bad, so I ought to try medicine and go from there. And then in A-level, I didn't get the grades, and thought I'm gonna resit and do that anyway. And luckily, I got in. So it wasn't a difficult path for me.
No.
But no one in the family had done it. It was just something. At 18, you don't really know what you're letting yourself in for anyway, do you? No. You kind of just plumb for something, and I was interested in care, I guess, and science. And went for that.
And how long you been a doctor for now?
So I qualified in 2003. So what's that? 23 years.
It is, yeah.
This year.
Yeah. And you do you start in the front line, junior doctors in the hospitals, or how does it work? Just out of interest.
Yeah. So it's 5 years at uni.
Yeah.
First couple, not really with patients, and then you slowly get a bit more exposure to the patients in those final 2 or 3 years. And then once you're qualified, you're kind of penciled in on the GMC register, the General Medical Council, and you have to kind of get through that year and get signed off to be inked on in permanent marker. Yeah. So that first year, I went to the Isle of Wight for 6 months and did some surgery there, and then I was in Portsmouth for 6 months doing medicine. Then you get signed off, and then you start choosing which direction you want to go.
Yeah.
And I wanted to go in the surgical route, so I did some A&E, which is a good foundation for anything, and some orthopaedics. And then I went off to New Zealand and worked in New Zealand in surgery for a little while, for about a year, and then came back. And then I worked in Oxford, at Oxford University, demonstrating anatomy. So you have to do dissections and things with the students. Did that for about 9 months, and then got a job down in Brighton and did that for a bit longer. And then I started to think, I was involved in general surgery, which is mainly cancer surgery in the bowel and things like that. And I got a bit fed up with just having people on the slab and not talking to them. I felt communication is something I enjoy. But also that there were people there potentially that I could be dealing with before their problem needed surgery. And that kind of dragged me into general practice, alongside the fact that I enjoyed education, and my wife was pregnant and we had a mortgage, and to do general surgery I was going to have to travel and things. So kind of all came together. I thought, let's do general practice. And that sort of took me on this path where I'm now. Yeah.
So how long was you a GP for?
So I qualified as a GP, I think, in 2011.
Yeah.
So what's that now? 14 years.
14 years, yeah. And you mentioned working in New Zealand. Was the health service much different there as here, or is it pretty similar wherever?
It's similar. They do it in a different way. Like there's a health insurance, and I don't totally understand it all either, because at the front line, people come and you treat them and they don't pay you. So from that perspective, it's pretty much the same. But there is some claiming going on in order to do that. And I think it works slightly different. So for a GP, for example, I think they claim for certain procedures that they do. So they're sort of incentivized to do more investigating, which could be good, may not be. And that's different here in the UK, where there's much more of a kind of a block contract. So in the UK, we're kind of told you've got to see your patients whatever they need, and you'll be paid about 150 quid a year per person on your list, and you've got to deal with whatever comes. You are then paid for some things extra, like if you do an ECG or something, to cover that cost. But it's a lot tighter and things than in New Zealand.
And have you seen a lot of change in the NHS and over the last 20 years, or has it not changed? Because I mean, I guess really from a user's perspective, it seems as though It's not as accessible to see a doctor as it used to be, or is that just perception?
I don't think it's perception, but I don't think it's just the health service that's changing. No. I think it's the people as well.
Do you think right?
And it's really hard. And the thing is it's a drift over that time, isn't it? So really hard to put your finger on what it is.
Yeah.
Because nothing has changes day to day or even year to year, but it slowly changes.
Yeah.
I think there's a really interesting report from the Office of National Statistics a few weeks ago, which demonstrated a reduction in healthy life expectancy in the last 10 years. So the life expectancy is plateaued. It dipped a little bit around COVID, but it's probably about plateaued, around 83.
Yeah.
83 years old. The investment in healthcare has been rising since the NHS's inception 70 odd years ago, exponentially, and yet we have got a plateau in life expectancy, and we've got a drop in the last 10 years of life expectancy, between 5 and 10 years of healthy life expectancy. So that's people without disease, right?
Yeah.
So people are living just as long, but they're living in ill health.
Right.
And that creates quite a demand.
Yeah.
So we've got people with lots of morbidities, so lots of diseases, and that requires general practice because specialists, they pick up a disease at a time, and guidelines point at one particular disease typically, but actually we're juggling a few. So deciding what is right for a person isn't just looking on guideline and going, it's that. It's actually teasing apart what might fit that individual more.
Yeah.
And that all sits with general practice. We've got people living with lots of problems that do need specialists, but they're on waiting lists that are a year long.
Yeah.
So those people, while they're waiting, still come to see the GP.
Yeah.
And we've got a rising health anxiety.
Yeah.
People, quite rightly, partly we improve life expectancy because we've made people more aware of things. So you may have seen an advert about lung cancer, if you've had a cough for more than 3 weeks, go and see your GP, which is right. But equally, the vast majority of those people don't have a lung cancer and still need to be seen.
Yes.
What, in general, that drift over time, I think, has done is that we're all a lot more aware of the potential for disease, and that creates an anxiety, which I think has a health burden in itself.
No, yeah. That's a really interesting view on, So what you're saying there is, it's interesting you pick up on health anxiety, because more and more people I know, have I got that? So more information is causing more people to visit, go, explore, whereas once upon a time you wouldn't known, and so the volume wasn't there. So it's a volume thing being driven by education.
Yeah. And there's this guy called Ivan Illich back in the 60s who kind of predicted this. He wrote this book called Medical Nemesis, because you can't ever beat that cycle really, in theory, he said, because you'll always deal with something, and then there's the next thing, and then there's people concerned. So we're really deep in that in the NHS. Yeah. And of course the aim now really is to try and just focus on prevention so much more. Yes. I think we've bought as much as we can in terms of helping health from this angle. Now I think we need to switch a little bit to much more preventative work. Yes. And hopefully that will make us more sustainable.
So just going back, so what we're saying, the life expectancy is 82,
83, I think.
83, but healthy life is really 70.
I can't remember the exact, because it's reduced by between 5 and 10 years, what it was 10 years ago.
And what do you think's driving that unhealthy life?
I think it's inactivity. We've talked about that already. So 1 in 4 of the population are physically inactive.
Yes.
I think it's poor diets. I've not jumped on being overweight because while that is a factor, now being overweight is normal now, right? So more than 50% of the population is overweight. Yeah. So that undoubtedly has an effect. But it's also what you eat. And people who exercise and who are overweight are better off than people who are of normal weight and don't exercise. Right. So it's complicated. Overweight is a thing, but what you eat is more important. What you eat, natural stuff is just so important. And we, as a society, I think often can't afford the natural stuff. No. It's really cheap to buy rubbish, isn't it? Ultra-processed foods is the thing. Yeah. And we don't really know what that does to us, but it's certainly not good for our microbiome, so the bugs in our gut, which affect in lots of ways. And I think we also therefore end up with too much sugar. Yeah. So we all end up with something called metabolic syndrome, which is where our bodies get kind of resistant to insulin, which is the hormone that goes up when we eat sugar. And even sweeteners probably contribute to that. So, right. I think it's physical activity, diet, and then there's something about relationships. I think actually, and there's a huge factor in us as human beings. We're relational, aren't we? Yeah. We're relational beings, and this famous psychologist called Adler would say that the smallest unit is the relationship. Actually, it's not us as an individual, because it's impossible to live completely as an individual. So if we focus on the relationship between people, more and more kind of online, there's 25% of the population, certainly in Eastbourne, and it'll be similar here, is lonely. Yeah. And loneliness increases stress hormones, so cortisol, things like that. And that drives a much higher incidence of most of the things that kill us. Yeah. So social isolation and loneliness is a huge thing. And I think that ironically we're more connected online, aren't we? Yeah. But that's not in a real sense. No. We go for a lot more short-term gain. So we talk about these dopamine hits. You go for likes or whatever it is. Yeah. A lot of our behaviours now, I think, as a society, are a little bit short-termist rather than those long-term gains. So it's sometimes actually painful, like cycling up the hill in the short term, compared to the long term.
So these issues, and I suppose we need to get on to South Downs Healthcare, which is what you started. So explain how. So, being a GP, how did you move on to how did that come about?
Yeah, so I was...
And what's the difference? Explain a bit about what you do and how you do it.
So I was a GP for about 4 years before that came along. So a GP partner. So what that means is a few GPs own a business. Yeah. And we have a minimum income guarantee, it's called. So you are given some money on the proviso that you look after the patients on your list. Yes. But every year the contract for that kind of changes, and it's very difficult to invest in the future. So as partners, you don't get a salary. No. You get the profit. Right. And yet you need mortgage and things like that. So you end up behaving very short-termist too, because you can't invest in that future because it's a small business and you don't really know where the money's coming from. You've got this small amount that you know is going to come, and that keeps things going. And then there are other things that come, and it's always last minute every year. You kind of go, oh, that's coming, this is coming.
That's really interesting that you say that GPs are a business, because I would think most people don't think of GP practices as businesses. You think of them as just... part of the NHS, and you get paid your salary, but I think that's quite interesting. Did you know that, Vic?
Yeah. And so we're part of the NHS family, it's called, and if you have a contract from the NHS, that puts you as part of the family. Yeah. I think there are loads of strengths to it. So you'll know as a business leader, I don't know if you've read the book Founder's Mentality, and it talks about 3 things. God, I have to remember them now.
That's all right.
But the first is owner's mindset.
Yeah.
So if in a business, the people who you work with have an owner's mindset,
Yeah.
they make decisions that are better for the service that you provide, right?
Yeah.
And we've all seen it. You go to a restaurant, you know straight away if it's a waiter who's the owner, often, don't you? So you get this different thing. So one of the things this Founder's Mindset book says, and they looked at hundreds of highly successful businesses over many, many years, and they found these 3 things. So the owner's mindset is one. If people have an owner's mindset, and the way general practice is contracted, it has that. Hospitals don't.
No.
You know, and we see huge inefficiencies often because of that.
Yeah.
The other is obsession with the front line. So being really obsessed with that user experience. And again, in general practice, you have that because you have this direct connection all the time.
Yeah.
And the third, so what was it? Owner's mindset, obsession with the front line, and a noble mission. So a kind of a mission that everybody pulls into.
A purpose.
Exactly. And actually in healthcare, that's quite clear.
Yeah.
Although, interestingly, if you compare small practices to a huge hospital, actually, when you talk to people in the hospital, they think, what is our mission? You know, is this just about getting people through, or is it being person-centred, or whatever? You know, actually, in a smaller team like a unit in a general practice, you can tick those boxes. And I think we work. People talk about general practice being a jewel in the crown of the NHS, and I think that's why, because we're close to the front line, and we have an ownership of how it works, and you go a bit more over and above.
Yeah.
And so it's quite clever, really, in the way in which they've contracted that.
Yeah.
The downside, though, is that it's very difficult to be long-termist and really invest in the future.
Yes.
And that's where the Federation came along, really, because we set up, so amongst all of the practices in the locality, we formed a company, so it's a social enterprise, that every practice owns, so they have a share in it.
Yeah.
And that practice is there to kind of do the things and take the risks that the smaller practices can't do. So it might be to just provide some evening and weekend appointments that is quite difficult to do at the smaller scale.
Yeah.
But also it was about having some, once we managed to create some profits, to invest that in the future. Whereas in that partnership model, it's kind of, you've paid your tax on it to start with. If you've got it's actually nearly impossible. We're not incentivised to.
So when you say it's short term, what do you mean by that?
In GP practice, in that we've got annual targets, and nothing else in terms of contractually. Really. No, it's always annual. Yeah, and the government will come along and they'll say, "Oh, we want to do this." Yeah, and then that's maybe 3 years, but the government put out their 10-year plan a little while ago. Yeah, we got a contract imposed last year that no GPs agreed with. Yeah, we're just about to get another one imposed from April that no one's really been engaged with. Yeah, and before we know it, it'll be a new government. And you're kind of going in a different direction.
Yeah. I suppose that's the problem being linked with governance, isn't it? Really, where it can chop and change, isn't it? Where really we are our leaders of our own destiny, and don't have that in the background. Oh, we're going to shift into another direction.
Yeah, because if a typical CEO of a business would take the mindset that they want to take their business somewhere that they would be able to pass it on to a child, better than they received it. So you're talking about a 20-year horizon, aren't you? And you really invest in things that don't make sense in years 1, 2, even 3. Yeah. And that doesn't really happen in general practice. Yeah. But at the federation level it can, and that's why we set up SDHC.
Yeah. Yeah. And has it been successful?
Depends how you measure success. We're still here, so I suppose the biggest challenge for us is that we rely on lots of short-term contracts. Yes. From practices, from the commissioners, and now from the hospital. So it's taken us a lot of time to get where we are, where we feel we're in a sustainable place. But not that long ago, we did have to make some redundancies. So it's been challenging.
Yeah.
But we clearly fill a gap in provision that people are noticing. So from a financial perspective, I think we're a success at the moment.
Yeah.
But I'm always looking for, the next contract is not about, a typical business where you are kind of convincing customers you're the best provider. We've got practices, the hospital and the commissioner, and that's it. If we're in favour, then we're okay. From a patient perspective, which is more interesting to me, are we a success? Well, I think so. We get a lot of positive feedback from our patients, positive feedback from our practices, and our staff love working there. So I think that's the better measure of success. Yeah. What I really want to know, though, in healthcare is whether you've met people's health needs, and we get a bit hung up on counting appointments, and access doesn't always mean success.
No.
And I can't at the moment give you that answer, so that frustrates me.
Yeah.
I think we're doing better, and we're going to start to measure that. But actually the proof is probably more in the pudding, again, 5-10 years down the line, when you start to see whether you're affecting people going into hospital that you might have otherwise seen in hospital and not. And that's a long-termist thing.
Yeah. What would you like to see change within the health system to make it better?
So at the moment, the government has said, let's shift. There's 3 main shifts they've outlined. So from hospital to community, from treatment to prevention, and from analogue to digital.
Yes.
And I think all of those things are very sensible.
Yeah.
What we haven't yet seen is the genuine shift in funding. So I suppose that's what needs to come.
Yeah.
The aim is that they'll be taking some money off the hospitals to give into those pots, those activities. The hospitals being split into acute, so meeting sudden demands, and more planned, where we would say those ones are okay. If it's planned demand, that's largely okay, and maybe we can do something about that in the longer term. But the acute demand, the unplanned demand, is something that we should be able to do something about quite quickly, because typically that might be because somebody... Well, the things that we can do something about is if somebody, has a bad chest infection and didn't manage to see their GP for antibiotics and ends up being admitted to hospital, we should be doing something about that.
Yes.
There are lots of examples, a little bit more complex than that we should be able to do about. And so in the next year, we should see some of that funding taken away from hospitals in order to try and prevent that. And there's a bit of a game there, whether we'll achieve that, because of course the hospitals are still going to need to provide the care if people turn up at their front door.
Yes.
And there's not significant additional funding, right? So the envelope remains the same. It's about shifting budgets.
Yeah.
But I think that's right. I think in the UK, we've got quite a track record, I think, of doing things really well when we're under pressure, especially budgetary constraints. We can't just keep on exponentially rising what we pay for healthcare.
No.
I think it is about finding ways in which we distribute those things better, and that is by working much more closely with secondary care, the hospitals, and primary care, as well as social care, and the huge, amazing kind of voluntary third sector who do a lot of good work. So that's what we're starting to do more of. And so your question was, what can we do better? I think accelerate what we're now starting to do. Get the money in.
So you think the right things are being done? It's just the speed and the funds to be able to get there.
Yeah, I think so.
Yeah.
And I think I'm impatient. I think these things also move at the speed of trust.
Yeah.
And we're working with people who often were set against each other, between hospital, who's saying we're losing money, we want to hang on to it.
Yeah.
So maybe it's my impatience as well.
Yeah.
But I think we do need to move quicker, or our opportunity will pass.
Do you think AI will have a big impact in?
Yeah, huge.
Yeah.
I think where we need to learn to use it, though, don't we? So you can just jump in, and quite rightly, we're quite there's a lot of governance hoops to jump through.
Yeah.
In healthcare. So it's not. I don't think it's really having a significant impact at the moment.
No. But
it can, and I was talking earlier that we're using it more and more back office. So just to firstly, we are starting to use it in one approved way, which is to almost record a consultation, transcribe a consultation, and do your notes for you.
Yeah.
I'm not sure how useful that is in the grand scheme, because there's still time in checking what it's written.
Yes.
And editing that, because it always needs a bit of an edit. And people who read their notes that they've written will recognise that helps with some continuity sometimes. And does it lose the skill of writing? What happens if it fails? So I don't think it's going to be a huge impact, that specific thing. But actually, if you think about it, if you're using that and the technology gets good, it starts to suggest, well, what about this guideline? Did you know this guideline? That might be relevant in this case. It might integrate with the patient's record and say, it might be relevant to this. Did you realise they came in 10 years ago with X, Y, or Z?
Yeah.
So I think embracing these technologies that may not help us at the moment, it will give it the space to expand and help us in time. Another one that's coming in, people probably frown, but an AI receptionist.
Yes.
It's a huge expense to have receptionists, and no matter how we try, people still call up at 8:30 in the morning and meet a huge queue, which you can't really meet. And actually using technology could really streamline how people get to see you. And you could still bypass it, so the people that can't use it still see someone. But if you can filter off a proportion of people who are perfectly served by it, I think that would be key. So that will come in, I think, in the next couple of years, a bit more mainstream. What we're doing at the moment, we started doing some audits of patient notes, so quality control, especially in South Downs Health and Care. We have some doctors who just audit some of our other doctors' work for a quality control process. And we can get AI starting to do that, to flag, and we're starting to do that because it's not involved in direct patient care. It's a bit easier to implement.
Yeah.
So that's really useful. It's going to expand hugely. The opportunities are vast, and I'm really excited about diving in. And I think what we need to do is create an element of safety around that experimentation, which is a bit more difficult in the healthcare sector.
Yeah, no, that's fascinating. And the future. So you're a GP lead, is this right? And chair of Sussex PCPC.
Oh God, this is so confusing. That's not right.
Is it not right?
Not
Okay.
quite right.
Okay.
So there's something called the Sussex Primary Care Provider Collaborative.
Yes.
Which is like a board made up of GPs, people who represent GPs contractually, people who work in the community, so the hospital sector, the dentists, pharmacists, community pharmacists, etc. The ICB, the Integrated Care Board, so that's the Commissioner of Healthcare across Sussex, also have a seat at the table, but they're not kind of voting. So it's a board constituted of all of the providers within the community of Sussex, really.
Yeah.
And when the Commissioner wants something delivered, they'll go to that board. So, for example, they might say, we want the service for people with diabetes delivered.
Yeah.
And that board will sit and say, this is how we think it should be delivered, how it's best delivered. And they work by a couple of principles. One is about sustainability, so they would, not say they can do it if it's not financed well enough, for example, or the model that they propose needs to be sustainable. And the other is around subsidiarity. So remembering that this single board that operates across Sussex, and we want to retain this ability to be fleet of foot and close to the patient, yet talk at scale. So this principle of subsidiarity that this PCPC, the Primary Care Provider Collaborative, work by, means that if at all possible, a service should be provided as close to the patient as possible. So that means, keep them direct to the practices if that's possible. And if not, you step up in levels of scale. So that board sits and they say, we think this and that, we should be delivered. Because it's just a board, it can't actually deliver or hold funds. So we've set up another company called Sussex Integrated Health, and that's a community interest company, and that's the company that I chair. And that's the delivery arm of this board, if that makes sense. Also complicated, but kind of had to be so because of the complex nature of the complex nature of the NHS, but also that's because of the complex nature of human need.
It is, and what do you think the healthcare will look like in 10 years? The future of healthcare.
What do I think, or what do I hope? Because they're such different things. Let's go with hope. Should we go with hope? Let's do that then. That's a much nicer conversation.
It is.
My hope is that back to relationships, isn't it? I don't want patients to feel they're talking to a machine, either struggling to get an appointment, struggling to get the help they need, and talking to machines. So my hope is that the health service is deeply personalised and personal, and able to be so because we're working alongside technology so seamlessly. So that it's it takes away the grunt work out of healthcare. And you're left with much more the relationship side of it. My hope is that people only come to need healthcare once we've exhausted that preventative side. So fewer people are coming in their younger years really with ill health. I don't see us having a longer lifespan.
You don't see that going longer?
I'm not convinced.
No.
We may, and this may be a side effect of what I want to happen. But what I really want to happen is to see a long health span.
Yes.
And so we have a compressed few frail years.
Yes.
But people enjoy their lives for much longer.
Much longer.
And when illness starts to come, then healthcare is there by your side in a highly personalised way. And so I'd hope that in 10 years' time people dip in and out of healthcare, but the emphasis being on out of healthcare, for those 7 decades of life. And then, it will come at some point that then we're helping people who have other conditions, but for a much shorter period, and able to focus on quality of life for those.
And I guess that comes back to where we started, really, isn't it? Is to achieve that, people need to be more active, eat better, and the other thing was loneliness, wasn't it? Was those 3 things?
It was around connection. I mean, I could go on. There are other things, sleep. I don't want to bypass this.
I know. We should really touch on sleep.
Sleep is a key thing, but mental well-being, you can't bypass that.
No.
And avoiding toxic substances as well. So it's easy to talk about diets, but there's other things. So there's a whole host of things, but we've got to be realistic too. And what I also want to focus on is it's not just about people doing that. I think it's also about how as a society make it easier to make those choices, because we're not willfully as a society treading the path of that's less healthy, are we? We're doing it because that's become the easiest path.
Yes.
And I think we need to make an easier path.
So do you see the diet injections as a positive thing? Because that makes it easier to diet, but not necessarily eat the right things, I guess. Is that the negative with it?
Yeah, it's really... I'm still out. The jury in my head is still out on that one.
Yeah.
Look, it's been transformational for many people.
Yeah.
We have got a relatively long-term follow-up on these medications, and there doesn't seem to be huge problems. But if you stop them, a lot of people put the weight back on.
Yep. Yeah.
So and the majority, I would say. So there's a real dependence there. I'm personally a little bit nervous that they do reduce muscle mass.
Right.
So,
yes.
I think there might be a slight increase in things like osteoporosis.
Right.
And therefore fractures and problems because of that. I'm not sure they've been around long enough to really see that come through, because that's probably more than 20 years.
Yeah.
So it's double-edged sword. Do they reduce morbidity, so illness?
Yeah.
Absolutely.
Really? Yeah.
Are they treating the root cause? No.
No.
Will they be a tool in our armoury? Yeah. Should they be for everyone? I'd hope we can aspire to be a civilization that doesn't rely on medications for that kind of stuff.
Yeah.
But it's not as simple as saying, you should just diet, forget the jab.
Yeah.
It's so much more complex than that. But I think there are other levers we have as a society that shouldn't mean we just rely on the jabs.
Yeah.
Or the tablets. It will soon be tablets.
Yes. Yeah. So we touched on sleep. Was that interesting? I suppose we should talk a little bit about sleep, because we are sort of linked. But the importance of sleep. What's your view on the importance of sleep?
It's hugely important. And I think this is a personal view, no data behind it that I know of. Yeah. I think as a society, I think we probably sleep worse than we used to.
Yeah.
And why is that? And when I say worse, I use that because some people might sleep for long enough but poor quality. So there's an issue here about quality versus quantity.
Yes, absolutely. Yeah.
And I think we might be affected both ways, mightn't we? So we're in a society that doesn't switch off. We've got our phones with us all the time.
Yeah.
Our work can access us all the time. And so that may well affect both quality and quantity. We've got increasing levels of obesity that leads to something called obstructive sleep apnea.
Yeah.
That leads to reduced sleep quality. And we've got, maybe this, I don't know, I'd be nervous of saying we're more stressed as a society. I think we've been through lots of different things, haven't we, in history, but stress is still here, and that clearly affects sleep quality.
Yes.
We're exercising less. So
yes.
It's not in our work, is it, to exercise? That affects sleep. So there are lots of things, and we know anyway, if you don't get between 7 and 9 hours of quality sleep, that significantly affects health outcomes.
Yeah. When I look at my sleep over the last 2 years, it's deteriorated, mainly due to work worries and stress and anxiety, more than anything else. I do have a very good bed, but it's only one element of it, isn't it? A bed. There's so much more that's about sleep and poor sleep. Do you think there's anything that anyone can do to improve their quality of sleep? I mean, other than the bed that you'd get from us, but I think first of all, what we need to do
all of us, including me, I think, is dig a little beneath our symptoms. So if you're tired, why is it? Okay, I'm not sleeping so well. So, but then let's dig again. Again, in business, I don't know if you do it. If something goes wrong, there's this 5 whys approach, isn't there, where you ask why 5 times and try and dig really deep. And we should probably do that with ourselves. So why am I, not falling asleep? Is it, or why am I waking up? But then, why is it that this is on my mind? And really dig deeper, because every single person will be different. Now, there are some very standard things that people can do to improve sleep, and they often work. So, for example, there's something called sleep hygiene that I'm sure you've heard of, and it's just a bit about the standard things maybe you should do in the lead up to going to bed, like reserving your bedroom for sleep and sex only. Taking a mobile phone out of the bedroom, not being on it. Interestingly, so one of this blue light from all screens, but the further from the screen you get, that blue light fades off. So even TV is not quite as bad as a mobile, because it's closer to your eyes.
Right.
However, it's highly stimulating, isn't it? So even a TV in your bedroom, no. But outside your bedroom, if it helps you relax prior, depending what's on, why not? So thinking about what are the things that gets you into a relaxed state is really important. But then what are we doing to deal with what's on our mind is really key, isn't it? And at the time of falling asleep, there's loads of things again you can do. So what's impossible to do is to say, don't think about work, because it makes you think about work, isn't it? So you need to have exercise of things that you do. So then there's a skill, isn't there? How do we? What effort do we put into mindfulness, or whatever type of meditation you might want to do to clear your brain? And there are some really useful tools. One I do with my kids is think of a word. Think of a word.
Boat.
Oh, so unorthodox boat. Let's do that. And then for every letter of that, you're going to have to think of a word.
Okay.
Beginning with that letter.
Oh wow. Yes.
So boat might not be long enough.
No,
just
no,
think
it's
of another
difficult
one.
means short and sweet. Unorthodox. Yeah, I see what you mean. Yeah.
And a lot of people find that as just a helpful way to think of things to clear the brain. So that's are really important. But and then there are other things that can throw up if you really dig deep. So a common one, for example, people who are stressed and a bit low, you end up in what we call this negative cognitive set. So your brain tends to think of negative things. It gets really talented at coming up with the bad things, not the good things.
3 o'clock in the morning.
Yeah. So actually just keeping a gratitude journal at the side of your bed can train your brain, because it's hard sometimes. Write 3 good things down for the day. But as you get better, it becomes actually also subconscious, and that can really help with mental health and things as well. So just tips like that, really. Also thinking proactively, so we think about one of the things that keeps people awake sometimes is your to-do list, right? What am I going to do? And certainly if you keep a piece of paper by the bed so you can write it down, you don't have to worry about remembering it. That's a good tip. But also maybe start to move on from to-do list to be list. How am I going to be? Am I going to be kind? Am I going to be whatever it is, what your purpose is? And I think starting to dig a bit deeper can start to help people, because kindness, for example, gratitude, even just random acts of kindness have a huge positive effect on our mental well-being, which in turn might help you sleep. So it's so intertwined, isn't it?
Yes.
But I guess I would just encourage people to dive deeper, do that with other people, because it's easier to talk it through or write it down. And then you start to see, maybe there's a bit of a gap in the way, I'm behaving and looking after my brain.
That's brilliant. I thought fantastic. And it's funny you say about the word thing, because we done some work with a sleep professional a couple of years ago, and one of the things it was a body scan. So you focus on your toe, so to try and distract your mind, and you feel your toe, and then you work your way up to under your foot, your heel, your ankle, and you feel each bit. And by the time you get to your head, whatever it was as either faded, and if it hasn't, you then go back down again. So that was quite a tip, and it's something I've used actually. Is just to distract those thoughts, those negative thoughts, the fears, the worries, the anxieties at 3 o'clock in the morning. So,
really, really powerful, and I think it's a habit. It's good to get into that kind of mindfulness approach. Absolutely.
Yeah, that's cool. Yeah, thank you, Nick.
Thank you.
Are we ready for some quickfire questions?
I think so.
Oh, God.
Yeah.
Go on then.
Okay.
I'm not very good at this.
That's fine, but you've been brilliant so far.
Yeah, it's good.
Some fascinating. So here we go. Question number 1. What is your greatest sporting outdoor achievement?
I thought about this. Well, I guess it's Ironman. I did Ironman in 2022.
Okay.
But I like to say that actually it's always cycling when I can.
Yeah.
Wow.
Yeah. I think that's a really good tip, isn't it? You know, instead of taking the lift, is to use the stairs. I tend to do it, but it's more because I'm impatient and the lift's not there, and I'll walk up the stairs. But so I don't know if it's done for the right reason. Mine's more impatience.
But it's interesting. The other thing about the question is being outdoor, and nature is key, isn't it? And actually, we know that people who experience more nature, or actually physically thinking, wow, has a huge beneficial effect on endorphins, on mental health, and sleep too.
Sure.
So the more you do outside, the better.
Yeah. What do you think that is? What do you think that is? Being outside, what makes that difference? Is it rather than being indoors?
Yeah, I don't know. I mean, I think there's stuff about natural light, isn't there? And we know that. So I'm sure you know about melatonin and how that affects sleep. Yeah. And so actually the more natural light you get in daytime, the more likely you are to then, get that nice dip and things at night. I think there's something about actually in a room, it's a bit stuffy, oxygen, carbon dioxide levels slightly off. But also it's so false, isn't it? You don't have any natural noises or anything, do you? No. And I think our bodies are just, we've had 40,000 years of evolution. Yeah. And for about 10,000 of those at which we started to make homes and stuff, but we're made outdoors, aren't we? Yeah. And I think some of our key chemicals like serotonin, oxytocin, and things probably more triggered, and they're the good ones. Yeah, they're more triggered outdoors.
The sunshine, isn't it lovely to see sunshine? And it's been very elusive lately, hasn't it?
Yeah, and it gets us down.
It does. Yeah, and it does, and it affects business too. Okay, question number 2: best advice you ever received?
That's hard, isn't it? My dad. I'm going to say this one just because I can't think of another. My dad said when I was thinking about whether I should do medicine, as you were talking about, I was 16 and that, and I listed off different things, and medicine was one of them. But it's the harder to get in. He said, "Well, always aim high because you can always take other things. But if you don't try high, you'll never know. So always aim."
Absolutely, yeah. Same with targets, isn't it? Or big, hairy, audacious goals. Yeah. You set a big target,
and it's okay if you don't make it.
It is okay. Yeah, absolutely, because you'll probably get halfway to where you would have got if you hadn't set that. So absolutely good.
So maybe the other lesson then from Paul, or I agree with that, isn't it? Is actually. Failure is okay. Like if you're standing now, you've succeeded more than times you've fallen, right?
Yes.
So we only succeed through failure.
Yes.
Maybe that's a better one.
Yeah. Good. One habit people should adopt to improve their health.
I was thinking about this. And this isn't quickfire at all, is it?
No. But they're good answers.
They're not. I'm a pleaser at heart. That's one of my flaws. I try and please people, so it really annoys me if I'm not doing what I've been asked to do. Sod it. Because another piece of advice to bring in is don't please people so much. So, what was the question? Habit.
Oh, habit. Yeah,
so,
habit.
A year ago, I'd have said do my teeth.
Okay.
So, habits stacking, I don't know if you've heard of habit stacking, I think is a really key tool. So if you think about habits, there's a cue, something that triggers you to start doing your habit. Yeah. So teeth might be just getting up in the morning. If you do it straight away, that's it. Some people do it after breakfast, but whatever, there's a cue that goes, oh, I need to do my teeth.
Yeah.
Right? Then there's the action, so there's three things. The cue, the action, the act of doing the teeth. And then the third thing is a reward. So there's always a reward if it's a habit. So in teeth, often it's that nice smooth feeling on your teeth, or the minty fresh, whatever it is, there's a reward. And if you do something enough to create a habit, what happens is the cue triggers a craving, so you almost can't help yourself.
Right.
So I can't help myself but do my teeth in the morning. Yeah. Because I'm craving that feeling. Yeah. Right? So habits are a huge key to our success if we're going to adopt healthy habits, right? Yeah. And all about bad habits, actually, if you think about what the cue is, you can start to avoid the cue, right? Because actually, once you've got the cue, it's impossible to stop yourself. And you can't erase habits because they're always there, but you can build stronger ones. So when you have one habit, we might call it keystone habit, you can stack them. So if you end up having a cue to doing the next thing, so say it's press-ups. Yeah. My cue to doing press-ups is licking my teeth and going, oh, they're so smooth. Right. And then you're going to do some press-ups, and then you feel really good because you feel a little bit pumped, and that's the reward. So the more you stack habits, the better you do with the changes you want to make. So brushing teeth, it used to be, but it's not now, because I've gone one further, and I'm a bit embarrassed about this, but I do, and it really annoys my wife. So what I used to do about a year ago, 18 months ago, I'd wake up and look at my phone and just get caught in this scrolling. Yeah. So it was a habit, right? Because I had a craving to look what notifications I might have or whatever. And before I know it, 20 minutes is gone. and I'd be really annoyed with myself. And I realised that is a habit. So I can't stop the craving, but I could maybe build a craving for something else better. Yeah. Unless I put my phone out there, but I need my phone by me because I might be called by stuff or kids, whatever. So it kind of didn't work. So now in the morning, I roll out of bed and do a plank. And that's my morning habit. And I actually have a craving for it, and then I can't look at my phone. So I do actually do a bit of scrolling while I'm in the plank, but then it's limited. And then so my morning, my best habit is that because everything is stacked on that plank, and I slowly add little things to it. Yeah,
that's cool.
A great story. Right, and a fourth and final question: if you weren't a doctor or a leader in the health industry, what would you be doing?
I think I'd be an entrepreneur of some sort, because I like doing new and exciting things, but I'm not sure how successful I'll be, so I might be unemployed or something. What I've really struggled with in things I've tried is getting to that viable business model, and in South Wales Health and Care, it's worked because you get contracts, but I'm not. I've really struggled with doing other things where you kind of need to convince people that this is the next best thing that they need to pay for, and reach that business viability. So there's the doubt that I would have. But I love thinking of ideas. I love trying to get people around a vision and an idea and pulling in one direction. So I'd like to think I'd be doing something.
But I think that is the entrepreneur though, isn't it? You know, it's not being an expert in everything. It's being able to bring the expertise and build whatever it is and have the followers behind you. So I would say that you are an entrepreneur in that respect, aren't you?
Yeah, I guess I am.
Yeah.
I guess I am.
Yeah. And you know, and we spoke to Richard Cripps last week, wasn't it? Last week, and solicitor, and it's exactly the same thing, isn't it? What we discover is you are an expert in health and in medicine, but being in the business world, you need to know a little bit about marketing, sales, and all of these other finance. And you bring in that expertise to fill those gaps, but it's having that knowledge, isn't it, to do that? So
yeah, one of the hardest things for me in that respect is that actually you can quash people, can't you? Because I've got some of the healthcare expertise. My biggest error is to kind of step in there, and actually stepping away is the most empowering thing you can do, isn't it?
Yes, yeah.
And that's why I need to come to places like this, so I'm not meddling. And
oh, that's brilliant. Yeah, well, that's the end of our podcast.
Thanks for having me.
Yeah, thank you, Nick. It's been really insightful. There's been bits of sleep, health.
Yeah, good.
I'm sure there's lots of people that take lots of bits and pieces away from this. So, carry on the fantastic stuff that you do. And I even myself, I'm inspired by, and what you didn't touch on with the AI was, and you developed a test AI to help people that are making appointments with doctors, to give them an idea of what to say with their.
Yeah, have you tried that?
Yeah. It was really good. Yeah, just to help people understand their symptoms before they go and speak to the doctor and save the time, wasn't it?
Yeah, if people want to download it, do it. It's free. But yeah, so restricted ChatGPT to not give suggestions of what's going on, but to help extract the information so you can and order it so you can then focus when you're with your doctor on a clear story of what's going on.
How often is it? Well, I know something's wrong, but to help you sort of express that, I thought it was a brilliant idea.
Thank you.
Yeah. So thank you, Nick. So that's the end of our podcast. Next week, we are being joined by Andy Clark from inside our industry, one of our furniture agents, and he's going to be talking to us all about how he got into our industry, the world of furniture, and his perspective and his life away from beds. You have a life away from beds, Andy? We'll find out what that is next week. So that's a wrap, everybody. We have new episodes dropping every single Wednesday. So don't forget to tune in. And if you want more unfiltered business talk, you can find me on Instagram, YouTube, and LinkedIn at An Unorthodox CEO. So that's it. If you're listening in the morning, good morning and welcome to a bright sunny day, because spring is on its way. And if you're walking through the woods, I'm sure you're feeling the health of nature and listening to us as you do so, and hopefully picking up some new, really good, healthy habits. And if you're settling into your bed, a Sussex bed, of course, you would have put your mobile phone outside the bedroom. Yep, so you've got no blue screens, and you'll be how are you going to be listening to us, though? Oh, yeah, that's not going to... AirPod. Yeah, I don't know. That's probably not good. Yeah. Do it before you go to bed. Listen to us. Have a good night's sleep, and we'll see you next week. Thank you very much. And good night. Bye-bye. There we go.
Good.